So the advantages we're seeing from robot-assisted laparoscopic radical prostatectomy include immediately less blood loss. We typically see blood loss in the range of 100 to 200 cc's. There's less postoperative pain, which leads to shorter hospital stay and earlier return of patients to their normal life activities. Early data also seems to indicate that there's improvement in terms of earlier return of urinary control and reported improvement in terms of potency preservation. I have another couple of questions which I'd like to put to you, Greg. One is there any risk in regard to the placement of the Hem-o-lok clips in the pelvis?
Risk in the sense of a foreign body would be one potential risk that I think the questioner is inquiring about. These are biologically inert, like other hemostatic agents, titanium clips, sutures, things like that can be used. So from that standpoint, if the question was directed along those lines, I would say no. Careful application is necessary to avoid injuring the neurovascular bundle, which is in close proximity to where the clip is placed. If clips can be placed, it would be preferential to do that maneuver as opposed to electrocautery. Even bipolar cautery has some degree of spread beyond the area of application, which can then injure the delicate neurovascular bundle. Patients who are already suffering from impotence, this would be less of an issue, obviously. One might even intentionally remove the neurovascular bundles bilaterally to enhance the margins on the specimen in that case. However, in the potent patient, trying to preserve these is part of the goal, part of the three goals: maintaining good cancer control, good urinary control, and preservation of erections that we strive for.
There's some mention by that questioner about concern about an MRI scan. I can answer that that is not of any concern. It will have no adverse impact. The average recovery time is another question, and typically the person is in the hospital for 24 to 48 hours. They are discharged with a catheter that may stay in anywhere from a period of 1 to 2 weeks, and generally their sense of returning to a full state of normal activity probably occurs within the period of a month, with the one exception of return of urinary control. That can vary from anywhere to immediate to up to several months. I typically see recovery in a period of 3 to 6 months. Any other comments from our panel?
I think getting back to some of the questions that you addressed on erectile dysfunction, I would agree that 2 years is probably the outside that I've seen in my practice in terms of people regaining their erectile function, and also the use of medical therapies. Also, the vacuum erection device is also helpful in that regard, enhancing the blood flow to the penis, preventing atrophy, and making the penile tissues more receptive to eventual return of nerve function. The nerves, if they're preserved and ultimately do function in all patients, will not function immediately due to the trauma of the surgery. The nerves will have to recover from that event, and that is where the lag time comes in between the surgery and the return of function. There are some reports of patients regaining their function at the 3-month point, as of the early time period. In my practice, usually I haven't seen that within the first 6 months, and the outside is about 2 years.
Warren, any comments in regard to the timing of postoperative adjuvant radiation therapy in patients who are found to have positive surgical margins or extra prostatic disease?
In those patients, we like to start as soon as we can. The criteria, number one, is complete postoperative healing from the surgery itself. And in the immediate post-prostatectomy interval, a lot of patients have some difficulty with incontinence. We like to see that settled as quickly as possible. I've waited as long as 6 months, though, because I think if you bring the radiation in prematurely while they're still having incontinence problems, they won't recover as well. We like to get that settled as much as possible first.
Well, I think that's about all of our time. I want to thank you for joining us this evening. This has been a panel discussion about the management of prostate cancer with special emphasis on robot-assisted laparoscopic radical prostatectomy. I'm Dr. Joseph Menon, joined by Dr. Greg Anderson, Dr. Warren Olds, and Dr. Seth Fagbemi, live from St. Joseph's Hospital and Marshfield Clinic in Marshfield, Wisconsin. Thank you. Good evening.